Good afternoon, everyone.
Good afternoon, Madam Chair.
Today is Tuesday, March 31st. You are in the Senate Finance Committee. Thank you all for being here. We sort of have shortened hearings today because they're crossover bills, but we're going to start with the lovely and hardworking Speaker of the House, Jocelyn Peña-Malnick, to bring us House Bill 1559. And I think she will have Delegate Griffith accompanying her.
Yes.
And the bill is Children in Unlicensed Settings and Pediatric Hospital Overstay, a very important issue. So, Madam Speaker, thank you for being here today.
Thank you, Chair Bidel. It's such a blessing to see you, and Vice Chair Hayes as well, and members of the committee. Today I have my friend with me, and he will tell his story. And this is something that we have been working together. My committee counsel is here if there are any questions on the bill. So good afternoon, everyone. The situations that have prompted the need for this bill are heartbreaking and simply unacceptable. It is our responsibility to end the practice of allowing Maryland's most vulnerable youth to remain in emergency rooms while their needs are not addressed and their trauma is further. This issue is personal to me. And a lot of you have heard this story. I've been working on this for years with Madam Chair and the Vice Chair of this committee and members of this committee. In 2018, I received a call from a school teacher who had a 14-year-old student, and I hope I don't trigger anyone, who wanted to die by suicide. I met the student and his mother at a local Panera Bread in Laurel, Maryland. They didn't have any transportation. And after talking to the mom and the child, I quickly knew that I could not just get up and leave, that he needed to go to the hospital. So I drove them to a local hospital. I waited with his mother and son. We got there Friday, 10 o'clock at night. Saturday, 5 o'clock in the afternoon, my husband came to get me. 15 hours later. And when I got in the car, those of you that know me well, I don't cry, but if I cry, you better run away because I'm really, really mad or I'm really, really disappointed. And I was so disappointed because what I noticed, what I waited, and I didn't say I was a delegate. I know I could have done that. I didn't. I wanted to walk through his experience. And I noticed that the nurse, after it was determined that they needed to keep him for further care, she will come every hour, every 2 hours, and she will make calls. She called Baltimore County, Baltimore City, Montgomery County, even Virginia, to try to find a placement for this child. And then if 2 hours went by and she would come back, we went all the way to the bottom of the list because she didn't stay on the phone. So I left the situation understanding the frustration of a family whose young child in a behavioral health crisis has to spend days in emergency room instead of a setting that could appropriately address his needs. Each year since, the stories about pediatric overstay have become worse. I have been approached on several occasions by hospital staff who feel like they're the only advocates for these children. Just this session, 2 nurses came to my office on their own time. They took off to share with me their deep concern about these youth who are spending their days in a noisy, unsettling emergency rooms without education, without friends or fresh air. Imagine that these kids are there sometimes for 7 months, 8 months. They don't get to go to school. They don't get to go outside and play with their friends. They don't get to be outside like a day like today that is beautiful in the fresh air. For Christmas, if they happen to be there for Christmas, they don't get to enjoy the family. They don't get to enjoy a cookie that is baked for you, a tree. It is the nurses and doctors that bring them gifts and try to give them some type of love. So this bill that you have in front of you tries to find a solution. For years, this state has been aware of the inappropriateness of placing youth in unlicensed settings and allowing them to remain in hospitals after being medically cleared for discharge. In September 2025, the ultimate failure in the system occurred when a 16-year-old Kayana Ward died by suicide while unattended after being placed in a hotel by our state. And you're going to hear more about that from my friend. House Bill 1559 that you have in front of you will end the state's practice of using unlicensed settings such as hotels, homeless shelters, and office buildings. And effective January 1st, 2027, it will end the use of hospital emergency rooms for pediatric oversight. It is not the place for them to be. But simply ending this practice is not enough. We must take steps to reform this system and be accountable to our most vulnerable youth. And this is what this bill does. But this bill builds upon a bill that we passed last year, House Bill 962, which required the Maryland Department of Health and the Department of Human Services to hire a pediatric oversight coordinator in each department to coordinate between hospitals, relevant state agencies and programs, because a lot of this is the lack of coordination and communication, and the providers of behavioral health services. I want to thank this committee and the chair, vice chair, the committee and staff, and the appropriations committee, particularly Chair Shetty and Chair Barnes, for their hard work. I know you're here. You really deserved a lot of respect. The coordinators require in 962 are required to ensure that pediatric oversight patients are transferred to and treated in the least restricted appropriate setting. House Bill 962, which we passed last year, also established a work group, Madam Chair, of the children on unlicensed settings and pediatric oversight to provide recommendations on how to seize these placements. Madam Chair and Vice Chair and members of the committee, the bill before you today reflects some of the legislative recommendations provided by the work group. Sometimes we pass these bills, we have recommendations, and we don't act on them. This bill, House Bill 1559, will. It would do the following. It would establish a senior advisor for children and families in the governor's office for children to oversee the Maryland Department of Health and Department of Human Services coordinators. It would establish a placement review panel and a rapid response team to take immediate action after being notified of a pediatric oversight patient. They must meet every day until they find a placement. And then you have these other layers to make sure that there's oversight, that we have different eyes on it, because that is what our children need. The bill further establishes an advisory council, a Maryland system of care for children, youth, and families that will require the various state agencies involved with the youth to talk, right? To meet, to examine the data, to develop standardized data collection and metrics across agencies so that we can serve these children in an honorable, dignified way. The bill before you reflects the hard work and input from the Maryland Hospital Association, the Governor's Office, the Department of Human Services, and Maryland Department of Health. The House vote on this bill was 127-0, bipartisan. I thank you for your attention. I thank you for the work you've done on this bill because, Madam Chair, you have been, we are each other's sidekick when it comes to this. And I thank you for that, and I urge a favorable report.
Thank you, Madam Speaker.
You're welcome.
Delegate.
Good afternoon, Chair Beidel, Vice Chair Hayes, members of the committee. For the record, my name is Delegate Mike Griffith, and I'm urging a favorable report on HB 1559. Let's give a little background how I got into this conversation. So some of you know, some of you may not, I was in the foster care system from the ages of 12 to 18. That was 1989 to 1995 to age myself a little bit. And during my time there, I discovered exactly how bad the system was. People joke, well, why are you Republican? Well, one of the things I discovered that I felt as a child that government didn't do a good job of raising kids. So the kind of little joke I have with some of my friends down here.
You can always change it.
So Yeah, so it was a really challenging time, and my issues I had during the foster care system wasn't with my foster parents. I had some pretty decent foster parents. It was with the system and some of the folks, and how the system kind of, treated me and other foster kids, and kind of I held that for the next, 25 or so years. Then when I had the opportunity to come down here and serve in House of Delegates, one of the things that I started to unpack was some of these issues were the same. These aren't issues that are tied to any one administration. This goes back 30, 40 plus years. They're systemic issues and historical issues within the system. And I've worked with the Speaker, Delegate Wilson, and a few others on trying to find ways to solve it. But it's such a big issue. And it's intimidating because the issues are so across the board and so deep, you don't know where to start. But a couple of years ago, I was turned on to the issue of the hospital overstays, and I started working on it kind of on my own. And then I discovered Madam Speaker had been working on that for a few years, and we were brought together on the issue, and she was gracious enough to bring me on that bill and allow me the opportunity to co-sponsor that bill, which produced the really great work that has produced this legislation. As the Speaker was saying, last year, Kenai Award, a 16-year-old foster child who is in our custody, us as the state, took her own life. And it was tragic and it was preventable. Her mom voluntarily surrendered her to the state because she was afraid she was going to take her own life. And unfortunately, the vendor allowed her to be unsupervised and then obviously ended up taking her own life. So that definitely shined a big spotlight on these issues. And it's one of those things where a number of things have kind of come together at the same time to create real change. We have a Speaker in the House of Delegates that cares deeply about this and has made it a priority. We have a Senate who cares deeply about this and has made it a priority. We have people on both sides of the aisle who care deeply and have made this a priority. So Kenai's law, which the JPR committee will hear later this week, addresses a number of other issues related to foster care, but originally addressed hospital overstays. But because the Speaker's bill was much more comprehensive when it came, Kenai's law addressed unlicensed settings, because the Speaker's bill was much more comprehensive when it addressed not only unlicensed settings, but hospital overstays, and was part of the recommendation of the work group. We came together as a body, moved that language in the Speaker's bill, and she brought me on as a co-sponsor, and then we're here together as unified front. Not politicians, not Republican or Democrat, we're here as people advocating for these kids to make sure these things don't happen anymore. And it's a real honor to have this opportunity to be able to come down here and have experienced something that was broken and be part of the effort to fix that thing that we've personally experienced. And I guess that's why we all really come down here at the end of the day. So again, I'm grateful for the opportunity, grateful for the Speaker, grateful for Delegate Shetty and Barnes and appropriation staff and all the people that worked on this, Speaker staff as well. And I would urge a favorable report. Thank you.
So, Madam Speaker and Delegate, I don't know if you participated in the call at the beginning of session from the Pediatric Overstay Work Group, but they announced to us that there were only 7 children in overstay. Well, they weren't counting the 25 that DSS did not take jurisdiction over. And so the whole lack of communication and the tracking. So I really applaud both of you for this bill, and to have someone tracking where are the children, how many are there. I just think it's so important because we're not communicating within our own agencies, and I really appreciate the bill that you've both brought to us. Thank you very much.
Thank you.
Thank you.
Do I have any questions from the committee? Not at this time, but thank you very much.
Thank you for your work and for caring.
Thank you.
This is, as you know, such an important bill, and I know that you have been working on this. It's so close to your heart, so I appreciate you.
I appreciate you, Madam Speaker.
Thank you. Have a blessed day, everyone.
Thank you.
Thank you for your time.
So that, whoop. And so the next bill is Delegate Kaiser, House Bill 1483, Clinical Professional Counseling and Social Work Out-of-State Providers. Thank you. Okay, Kaiser, I'm sorry, I didn't bring up your panel. I'm a little overwhelmed from the last hearing. We have Andrew Mansfield and
Yes,
Sarah Trescott.
Thank you, Senator. Thank you, Senator Beidel, Senate Chair. Thank to all of you. I'm here today on House Bill 1483, a bill aiming to create counseling continuity of care option for Marylanders. So, I'll back up a little bit. We did have a bill last year that did this for students, and now we're trying to do this for more people. And so let me give, it's not surprising to you that people move around this country. They move, a lot of people move to Maryland, whether it's military, their employment, school, or just all the great things we have to offer in this state. So people are coming here, but if they are, if they currently have a mental health care relationship with a provider, they then have to change that when they cross state lines. And the concern is about continuity of care. People with significant issues can often take a long time to find the appropriate counselor. And then if they move, they suddenly don't have that person and don't have access. And so allowing patients a limited period of time to continue their telehealth treatment with their existing provider ensures stability while they transition to care in Maryland. Some people may bring up different compacts that are out there for counselors, for social workers, for psychiatrists, for psychologists, and all of that. And you're correct. What we should really have is either a federal policy that makes this possible across the country, or through these compacts where states work together and allow for these exceptions. But that's not a reason not for Maryland to do something, and certainly in the meantime. So right now, as drafted, House Bill 1483 authorizes out-of-state licensed professional counselors to provide a limited number of mental telehealth services to their patients who are newly residing in Maryland. In advance of the House committee hearing on this in front of the Health Committee, we had prepared an amendment that would implement this continuity of care option through a temporary license rather than through a limited licensure exception. And so we offered the Health Committee really two options and to see what they would do. And ultimately, the Health Committee chose to move the bill without the amendment. And so I guess what I want to get to at the end is remembering that there are different solutions, and there's different solutions being offered. But ultimately, ultimately this testimony speaks to continuity of care. So I would say, do as you please, and certainly as this committee and their expertise looking at the different options, and remembering how important that therapeutic relationship is. And I think if you look at all the testimony that's being provided, the support and the opposition, they all agree that continuity of care matters. They all agree that that therapeutic relationship is important. They go at it differently, but I'm hoping we can come together and make this easier for people as they move into our state. So thank you, Madam Chair. And the bill passed the House 135-0. I urge a favorable report on House Bill 1483. Thank you.
Thank you. Andrea and Sarah, you're going to testify?
Yes, Madam Chair.
Thank you.
Yeah, good afternoon, Madam Chair, Mr. Vice Chair, members of the Finance Committee. I'm Sarah Trescott, board member of the Licensed Clinical Professional Counselors of Maryland. This bill is modeled after Virginia's 2022 Continuity of Care bill as it relates to an out-of-state, fully licensed counselor in good standing, which is a nationally recognized standard, not a loophole, with an established counselor-client relationship to provide temporary care when their client is physically located outside their home state. No Maryland residents are harmed. But what if our board would receive a complaint? As in Virginia, it would be referred to the therapist home state for disciplinary action. If discipline is upheld, the therapist is no longer in good standing and therefore cannot participate in this process. The board believes a temporary license is required. Virginia does not require one. More importantly, who's going to issue the license at 3 a.m. on Thanksgiving morning when a counselor's suicidal client has stepped across Maryland's border? The client is in need then, not at 9 a.m. Monday morning. Sadly, they could literally die waiting. When speaking with Virginia's Board for Counselors, they indicated no adverse actions. LCPCM requests a favorable report on House Bill 1483 By positioning Maryland as a regional partner, it ensures that Oversight follows the license, the counselor, and the client, rather than stopping at an arbitrary state border. Thank you for allowing me to testify today.
Thank you. And Andrea?
Thank you, Madam Chair, members of the committee. Andrea Mansfield of Manus Canning and Associates, representing the licensed professional counselors of Maryland. I'm really not exactly sure what I can add that the sponsor and our client has not already stated, but really want to thank Delegate Kaiser for her leadership on this bill and her willingness to address these matters. As we stated, this really is a targeted, limited, one-time continuity of care exception that we are seeking, really to ensure that individuals needing this help in times of crisis can get it quickly. So our concern would be a temporary license could delay that from actually happening. So it would be our preference that the bill is voted favorable as amended by the House and presented to you today. Thank you.
Thank you. I have a question from Senator Lamb.
Just one quick question, because I was looking at the testimony that's in the bill folder. Can you just clarify for us, like, this was, I think, a point that was brought up by the board of professional counselors and therapists. Not all states take complaints from patients in the same way, that, especially if they're not in the same state that they're concerned about. So it's not clear, I think, from this bill that all home states would take a complaint about a person that's actually in Maryland. So how do you envision that would kind of play out?
As it is in Virginia right now,
Go ahead, please.
I'm sorry, Senator, that if that Virginia resident who is temporarily in Maryland would have a complaint, normally what would be recommended is that they would either call our board in Maryland, and our board would refer it to Virginia's for disciplinary action or an investigation, or preferably have that client call their board in Virginia for their therapist where they are licensed for the appropriate action.
So the action wouldn't come from Maryland then, right?
No, sir. It's where the therapist is licensed, just as it is with the counseling compact. Same principle. It's just, unfortunately, there's no mechanism in the counseling compact to address continuity of care.
So would you be anticipating that all states would kind of behave along this line? That, obviously we're using the example of Virginia and Maryland here, but let's say it's Idaho and here.
I'm not sure about Idaho, but Washington, D.C. does.
So the patient then would report it to, if they were physically in Washington, D.C., they would report it to the D.C. board, who would then refer it back to the Maryland.
No, sir.
I think your scenario was confusing. Where are you saying the person's a resident of, and where are they visiting? I think they're.
Let's say the patient or the person's a resident in Maryland.
And then they cross state into D.C.? Is that?
If they are, yeah, I guess if they're not in their home state, yeah.
Actually, when I said it would harm no Maryland residents, no Maryland resident would actually be involved under this bill. It would be the Virginia licensed counselor's client who comes across the Maryland border, say for a TDY of 2 weeks to NSA. They have the opportunity then to still have a relationship, client-counselor relationship with their therapist. And if there's a problem then, hopefully that client would contact, for example, the Virginia board or the Washington, D.C. board, and they would take the appropriate action to investigate and decide if disciplinary action is warranted. If disciplinary action is warranted and there's a finding, that therapist can no longer participate in this process because they are no longer in good standing.
Senator, I would add, I think you're bringing up a legitimate concern, and I think it's something that the board is speaking to as well. But I think, as with most policies we have, there's on the tally of what's on the plus and what's on the minus, and we're always trying to reduce the minus. And I think here, the bill, as was described, this is about people coming into our state, not Marylanders going elsewhere, though the hope is that other states would do this same thing, and I think some have. It's that on the plus side, the immense number of people who have that ability to keep that continuity of care is what's there. Having higher standards in our state, ensuring that our board had the computer system and the capacity to track the different things are things we should be investing in. But we can't make the other states do something, but we can help people while they're here. And some of them are here temporarily, like you said, with a 2-week stint at NSA, and others are here who will find long-term care here, but at least for the 6 months, they can keep their prior counselor. I mean, again, I think the therapeutic relationship is so important.
Okay, all right, thank you.
Thank you, Senator. I don't see any other questions for this panel. We do have a couple unfavorable, so this panel is complete, and we're
Thank
going to...
you. Thank you, Madam Chair.
Thank you. Tamiloba Quadri, State of Maryland Board of Professional Counselors and Therapists, and Kevin Meenan, Board of Social Worker Examiners.
Good morning. Good morning, Chair, and members of the committee. My name is Tomilo Baolani Ikodri. I'm the Executive Director of the Board of Professional Counselors and Therapists. Today, I came to express the board's position on the House bill that is before us today. And while we are in support of the idea of continuity of care and the importance of client therapist relationship continuing outside our state's borders, one of the things we're concerned about is one of the major mandates of the existence of the board itself is to be able to protect everybody within the state of Maryland. The idea of allowing outside therapists to practice in Maryland, even if it's for 6 months, without any form of registration, we believe would put the people that they are taking care of at risk. If you think about it this way, it's like a driver that has a Florida license plate over speeding in Maryland, and then the police has to call Florida to say, can you issue a ticket to this driver? That may not necessarily work in terms of being able to ensure oversight. We want to be able to control what happens in Maryland. We want to be able to protect the people of Maryland, which is our mandate as a board. So while we support continuity of care, we want to retain the idea of a temporary license. Fine, like the earlier lady testified, we know that there are situations where there might be emergencies. Maybe an individual needs care from their therapist at a particular time when the therapist cannot reach the board to get a license. But then that is just one side of it. What happens to cases where the therapist does something wrong and there is no protection for their client? It doesn't matter if the origin state of the client is Florida, is Virginia, or anywhere else. The moment they are in the state of Maryland, they are our responsibility, and we should be able to protect them. Thank you.
Thank you. Kevin?
Good afternoon, Madam Chair and members of the committee. My name is Kevin Meenan. I'm the board chair for the Board of Social Work Examiners. The board has protocols in place allowing an out-of-state licensed providers to obtain a Maryland license. Last year, the House and the Senate both passed, and Governor Wes Moore signed into law the Social Work Compact for the state of Maryland to become a part of a compact system that increases mobility and supports military families in member states while also ensuring protection of the public for Maryland residents. The process for the compact ensures jurisdictional authority and enforcement, while this bill presents with potential loopholes and gaps in enforcement. In the event a worker or provider violates the Practice Act, Maryland would not necessarily have the authority to enforce disciplinary action, as Maryland only retains enforcement provisions over Maryland licensed workers. We would ask that this committee allow previous legislation, the Social Work Licensure Compact, to accomplish the goals seemingly set forth in this bill, while also ensuring proper enforcement of standards, and to please recommend an unfavorable report on House Bill 1483. Thank you.
Thank you. Senator Reedy, you have a question?
Thank you, Madam Chair. Yeah, I'm just kind of curious here. Looking at the bill, and it's got broad support. What is the capacity of the boards for registration right now for folks to register and get? Like, I thought the issue of registration was coming up. What is your board capacity? I know there's a couple boards represented, but I mean, what is your two boards' capacity for registration right now?
When you say registration, you mean registering licenses?
Yes.
Currently, we've been struggling with the fact that we don't have enough staff, but we are currently hiring more licensing coordinators to be able to fill this gap. And although we know that it is obviously more responsibility to take on additional work of temporary licenses, but it is our mandate, and it is to protect the citizens of Maryland, and we are not shying away from that responsibility.
So you don't want the bill, but you want to have like a temporary licensure program for this?
Yes, temporary licensure actually exists already. This bill is trying to take that away, and that is what we're trying to say, that we want to retain that temporary license.
But it's the frustration that I've heard from some folks in social work and social work applicants is the slowness with which licenses are getting approved. And there's been issues with testing too, of course. We've been through that in this committee quite a bit. So I guess I'm curious. There may be I know there's some pros and cons here with this, but I guess I'm just curious, if you don't have the capacity now, won't this bill help relieve some of that burden? At least in the meantime.
Yeah, the reasoning behind that is very correct. But what we are thinking about doing, and we are actually in the process already, there's a hiring process that requires requests to recruit and all of that, which we've gone through. We plan to have a dedicated staff member take care of all the temporary telehealth bills. In that scenario, there will be no delays in processing them, because we know it is just for a 6-month period, and the time frame is usually very short. So there will be a dedicated person in charge of taking care of that.
What has been the holdup in getting that done up until now?
We were coming out of a blanket hiring freeze from the state of Maryland, and so we were not able to hire into those positions. At the same time, most of our positions are contract positions, so they are not exactly the most attractive to the most qualified people. But right now, one of the things that we're trying to do is just at least try as much as possible to fill those vacancies with people that are qualified enough, now that we've been given a little bit of exemption to hire.
I guess when you say that about number one, I thought we were still in a hiring freeze, but maybe we're not. But number two, like that's the job of the board, is getting to register. What else are we doing? I mean, I know there's enforcements and things like that, but why would we need to hire more people to do? You just don't have enough people doing the job already?
Yes. So at the time I joined the board, we had 3 licensing coordinators processing over 1,000 applications. So obviously it was a lot of work between them. And then we're also doing paper applications, which means that everything is done by hand. Between receiving it from USPS, landing in the mailroom, and then taking it from the mailroom to process, to send it to the actual licensing coordinator to process. So all of this creates the delay. But then, in the next couple of weeks, we are also launching an online system that allows us to be able to eliminate that paper application process that slows things down. In this case, that temporary license would also be part of this online system. So it'd be easier to process and faster to process. So whether even if we don't get as many licensing coordinators as we want through the door quickly, we know that that online system itself would help facilitate this process.
Yeah, I guess I didn't realize there wasn't already online capability. Okay. Thank you for your answers. Thank you, Madam Chair.
Thank you.
Senator Lamb?
Thank you, Madam Chair. So I just wanted to get this straight. So you're saying that you still process these applications by paper right now?
Yes, Senator.
Okay. Because, you know, in this committee, I think we had a briefing earlier this year about just the health occupations boards, and that there may be some ability to have a lot of the back-end and administrative tasks like combined so that some of this can be streamlined through. It just seems like a lot of effort that, you know, in 2026, we're still processing these by paper, which is, you know, I think all of us agree we need to try to get these through as expediently as possible, and that certainly is a big rate limiting step to still have paper involved in all this.
Yes, the paper aspect sets us back in terms of our efficiency, and that is why, while we're waiting for MDH to give us a permanent solution to the automation process they're working on, we're able to create basically an internal workaround that helps us to be able to take online application. We've not started taking it because we're trying to ensure that we give the members of the public enough time to be aware of this online system coming up.
So you mentioned this online system that hopefully will be in place by 6 months. Is that a permanent solution, or is that the workaround solution?
So it's the workaround, and it's going to, we're going to start using it in about 2 months.
So when do you anticipate the more permanent online solution coming in line? Because this has been an issue, I guess, with MDH, where you know, you don't have full control of your budget. You're going back to the department to ask for additional support and resources. You're not always getting all of that, even though you're collecting the fees from licensees but you don't have full control of the budget. And so there's this back and forth that we've touched on in this committee and other briefings that we had earlier in the session, other committees and sessions as well, even outside the legislative session, that this has become an issue that's still not cleared up between the department and the health occupations boards, right? And so when are you anticipating being able to have a full, more permanent resolution to an online system that doesn't require you to do everything by snail mail?
Honestly, the timeline is not clear yet as far as that is concerned. The control of that process is with MDH. And right now, of course, there's been constant communication between the boards and the IT company that we expect to eventually use. But as far as the timeline for when it becomes operational, we do not have that just yet.
Okay. Well, I mean, obviously this bill is trying to address some of the time urgency here and some of the concerns here. That seems very real, given that you're still operating on snail mail in 2026. Is the Board of Social Work in the same spot, or
Thank you. So the Board of Social Work, I don't believe, is in the exact same spot because there's a lot of online capacity for applications, and there is an expedited process for individuals coming from another state to become licensed in Maryland.
Okay. I mean, again, this speaks to having some maybe more unified back-end administrative support for all of the health occupations boards, so you're not all kind of replicating the recreation of the same wheel here.
Right. And just anecdotally, I did work with somebody that was trying to get licensed. She was asking me a lot of questions. Within the last week, she got her, okay to take the exam in less than a week, from the social work examiner board. So it's faster, I think, than what's been reported previously. But I know that there's still kinks to work out.
Okay. All right. Thank you.
Thank you, Senator. I don't see any other questions. Thank you all. That ends the hearing for Senate Bill 1483. Delegate Shetty is here. We're going to do House Bill 772, Behavioral Health Rate Methodology Modernization, Work Group Establishment and Study. Thank you, Delegate.
Thank you, Madam Chair. Wonderful committee friends. My name is Emily Shetty, and I'm here to respectfully request a favorable report on HB 772, which will establish a commission to develop transparent, cost-based reimbursement methodologies for certified community behavioral health clinics, CCBHCs, and outpatient mental health centers, OMHCs, while also establishing a work group to kind of work through this study that is already actually been going on for a little bit of time at MDH. So let me just kind of step back and talk a little bit about what's happening. So about 10 years ago, there was a large bipartisan bill passed to address the opioid crisis, the HOPE Act. As part of that bill, MDH was required to commission a study on some of the behavioral health system shortfalls and what our existing system needs to ensure that providers are able to keep the door open and that patients are able to get the behavioral health support that they can. That study was contracted officially through the BPW, I think, last summer. So it took about 10 years for the study to actually begin. The study has quickly, I think as part of it, we've realized that part of that study really could benefit from having a little bit of improvements, including the development of really transparent methodologies on how we are reimbursing our behavioral health providers. This can really best be done in consultation with work group members that include people who are delivering the care on the ground. And so what this bill does, as just kind of what it does, is that it keeps the legal aspect of the study within the Department of Health, but actually runs the work group that will be working with the Department of Health to complete the study in MHCC. You might recall that Senator Lamb had a very similar bill earlier this session. They were cross files. My bill that came over to you guys is now supported by MHCC, MDH, and the advocates. So there's no opposition to this bill, and will ultimately bring the study to its conclusion, hopefully, with some really concrete goals. That's what the bill does. I look forward to answering any questions, and I respectfully request a favorable report. Before I conclude, though, I just want to take a moment to thank Chair Beidel for your many years of leadership here in the Senate, your public service, and for being a really wonderful role model to women in politics across our state. On both sides of the aisle. I sort of had the first opportunity to meet you, really meet you in person last year when we were sitting together in a meeting with the Department of Human Services. And although I had known you, obviously, I guess it was the first time we had formally met. And when you introduced yourself to me, I sort of had a moment of panic fangirl of, oh my goodness, I can't believe we haven't met yet, but I'm so grateful to get to work with you then and maintain gratitude for all that I've been able to learn from you over the years. So thank you so much for your service. We will very much miss you when you retire, though I know you're not going to go far. So thank you, committee. I'd be glad to take any questions.
Thank you,
on my fangirling or otherwise.
Thank you for your kind words, and I've been so in awe of the work that you've done. You came into the House and just immediately were grounded on important issues, so I really appreciate your work. I do have a question on your bill.
Yes, ma'am.
You have 2 senators and 2 delegates. It's really tough for the senators to get 2 senators, particularly in an election year, so that may end up being a problem in the Senate. We'll try and get to your votes, but that's a little bit of an issue here. Sometimes they're like, I'm not going to vote for the bill if I'm going to get appointed. So.
That's a very helpful point that I had not considered, and I welcome the amendment. We would immediately conform it in the House if needed.
Thank you.
Put Senator Kramer on it is the recommendation I've heard.
That's what happens when you miss a meeting, right?
That's right.
Senator Lamb, you have a question?
Yeah, thank you for the sponsor. I presume you would have no opposition if we took, so I think we were working on this together, and then I packaged additional provisions in because of our bill limits to amend this bill, the Senate bill, back to align with the House bill, just to make them cross files again.
I would love that opportunity.
And I guess I'd probably be volunteering myself to serve.
I would love both opportunities. Thank you, sir.
All right, thank you.
Yes.
I don't see any other questions. Thank you very much for your testimony.
Thank you, Madam Chair. Have a great day, everyone.
You too.
Thanks.
House Bill 945, Delegate Sample Hughes, Nursing Homes and Assisted Living Facilities, Notification of Investigations and Establishment of the Healthcare Quality Improvement Initiative. Thank you, Delegate.
Thank you. Good afternoon. That was certainly a mouthful, but certainly noteworthy. I'm Delegate Cherie Sample Hughes, representing District 37A. Chair Vidal, Vice Chair Hayes, and members of the Senate Finance Committee, thank you for the opportunity to present House Bill 945. I am pleased to share that this bill passed the House of Delegates with strong support and has been strengthened through the amendment process. At its core, 945 requires the Maryland Department of Health to notify and consult with the local health department when the department initiates an investigation of a nursing home complaint alleging actual harm. The purpose is straightforward: to ensure that when serious concerns arise, there is a local partner engaged who understands the community, available resources, and emerging public health trends. This bill does not interfere with the work of the Office of Healthcare Quality or federal requirements around unannounced inspections, as that was an initial concern, but it's not there. Notification and consultation can occur after those inspections take place, preserving the integrity of the process. What this bill adds is coordination. We know that in 2023, there were approximately 9,000 unanswered complaints involving nursing home facilities in Maryland. That reality calls for a more collaborative approach, where the state is not operating alone, but in partnership with local health officials. The House amendment expands the bill in an important way. It includes assisted living facilities and establishes the Healthcare Quality Improvement Initiative, along with a task force to examine broader systemic challenges impacting care, affordability, and access. This task force is designed to be active, inclusive, and accountable. It requires engagement with healthcare providers, advocacy organizations, and the nursing home and assisted living facility communities. It allows for the creation of work groups to focus on specific issues. It also requires collaboration with the Maryland Healthcare Commission to strengthen how data is analyzed, shared, and used to improve oversight and transparency. I know recently in our local area, we had a rise in UTIs, urinary tract infections, as well as bacterial gastrointestinal issues, and our local hospital picked up on that and saw that it was some issues that were happening in the nursing facilities. And with having this level of coordination, the health officer can help maybe identify what resources are available. So what is very important with this is that it brings together more voices. It brings together the family members and frontline workers so they can really challenge what is happening, identify what is happening, but work together on those issues. I want to be clear that this is not a punitive bill. It is a partnership, and it creates a framework where the state and the local departments can work together. Ultimately, House Bill 945 strengthens oversight while also supporting facilities and delivering safe, high-quality care to vulnerable population. House Bill 945 is about coordination and transparency, and I respectfully ask for a favorable report on this bill. Thank you.
Thank you, Delegate. Senator Mouch, you have a question?
Thank you, Madam Chair. Great to see you this afternoon. I want
Likewise.
to thank you for bringing this bill. It is a fantastic concept. Thank you for your leadership. It's going to make a big difference.
Thank you, Senator.
If I can help you any way, please let me know. But you've got this.
Absolutely. I appreciate you for saying that, Senator, because as you are aware, during the interim, we heard from a lot of constituents about the challenges in our local nursing homes. And I know we try to put our heads together and figure out what we could do. And then the last thing I just want to add is that I had so many constituents that testified in the House, whether it was written or whether it was verbal, and they just poured out their hearts. And so this is an opportunity to try to hear those family members and take care of that vulnerable population that's sitting in those nursing home rooms and assistant facilities.
So Senator Mouch, I think you just volunteered to serve on this work group.
And we need one.
You said anything you could do. Thank you. Senator Jackson.
Thanks, Madam Chair. Hi, Delegate. How are you?
Hello.
Great bill. You said there were some amendments. Did that address, because the Department of Health is saying that it's saying the Office of Health Quality, Care Quality is obligated to follow strict federal rules that investigations must be unannounced. Did you did the amendments address any of that?
Yes, if I can, I'll just expand upon that. So when the bill first came in, I said that the notification needed to be done immediately, making certain that the health department and the nursing home facility, they were like in conversation and communication immediately. That then I would learn was that the federal regulations around making certain that an inspection occurs first before letting anyone else outside of the nursing home know that they're coming. And so therefore I understood that, and we knew that with these amendments that it gave that space and time, but not too much space, where we could still make sure that the issues are addressed. So the amendments clarifies the timing, and it also clarifies the fact that we have to, all work together and to do that level of communication where we're not affecting any of the regulations for state and federal.
Okay. Thank you. Thank you, Madam Chair.
And they helped us write this as well, the amendment.
That's good to know. I don't see any other questions. Thank you so much, Delegate.
Thank you so much.
So next, we have House Bill 1284, Delegate Gazzoni. And it's Residential Service Agencies Private Duty Nursing On-Site Nurse Training Programs. Thank you.
Good afternoon, Chair Beidel, Vice Chair Hayes, who's actually not there, but hello anyhow, and members of the Finance Committee. I am Delegate Pam Gazzoni, representing Howard County's District 13, and I'm here in support of House Bill 1284, which would enable residential service agencies, or RSAs, to provide training to a licensed private duty nurse in place of clinical experience requirements. Private duty nurses are an essential component of Maryland's healthcare system, providing in-home care to vulnerable patients, often children with complex chronic conditions, so they can lead full and meaningful lives. Their services ensure continuity of care, reduce preventable hospitalizations, and deliver compassionate, individualized support that safeguards patients' safety, dignity, and overall well-being. Yet, like many areas of the healthcare workforce, a complex web of issues has led Maryland to face a shortage of private duty nurses. Without adequate access to these services, many children are forced into prolonged stays in far more expensive settings, such as hospitals, and separated from the comfort and stability of their homes. This shortage is compounded by the fact that Maryland has experience requirements for private duty nurses that are among the highest in the nation. The Maryland Department of Health requires all private duty nurses who work with individuals under 19 years of age to have at least 1 year of clinical pediatric experience within the last 3 years. Maryland is the only state with this mandate. Most other states allow registered nurses and licensed practical nurses without extensive experience to provide care with the appropriate training requirements and generally under supervision. HB 1284 brings Maryland into line with other states by ensuring that private duty nurses receive the appropriate training necessary for high-quality care. It would allow residential service agencies to employ registered nurses who have not yet met the state's current experience requirements, provided that the RSA has an MDH-approved training program, ensures clinical supervision by a nurse qualified for private duty nurses, and conducts frequent competency evaluations. Implementing this legislation has several advantages. First, it will increase the supply of nurses, especially LPNs, qualified to provide private duty nursing services, helping to alleviate the current shortage and provide the needed care. It enables residential service agencies to tailor training to the unique needs of their patients, equipping nurses to effectively address the specialized care requirements of those they serve. Finally, it will bring Maryland into line with other states in the country, making private duty nursing more accessible and preventing us from losing qualified nurses to states with less restricted regulations. Just want to note that this was voted out of the Health Committee on the House side, 15-0, and voted out of the House itself, 135-0. And also, while you may have noted that the Board of Nursing has a letter with some concerns about this, Maryland Department of Health, I have been in contact with them, and they do not have concerns with this bill. Thank you very much for your time, and I'm happy to answer any questions.
Delegate, there was unfavorable from the Board of Nursing.
Yes.
No, I'm sorry, from the Department of Health, but has that been corrected?
The Board of Nursing had sent Unfavorable, yes. When I talked with the Department of Health about the bill, either just before or just after the hearing on the House side, they were fine. They did not have any concerns or objections to moving the bill forward.
Okay, I'm a little confused, but thank you. Do I have any other questions for the sponsor? Thank you very much.
Thank you. Thanks.
House Bill 1372, Public Health Office of Healthcare Quality Information and Maryland Health Centralization Commission.
Thank you, Madam Chair. And I've got Ken Weaver, who's our liaison from the Office of Legislative Audits and DLS, who's been with us. Thank you, colleagues. For the record, Delegate Jared Solomon, District 18, here to present House Bill 1372. And I am here in my capacity as the House co-chair of the Joint Audits and Evaluation Committee. And before I get into the bill, I want to just thank a couple of folks. I know folks are in and out, but I wanted to thank your members of your committee who also serve on the Joint Audit Committee on the Senate side, Senator Lamb, Senator Washington, Senator Reedy, who I know just stepped out, and Senator Hershey, who was here earlier. I know have been really wonderful partners with Senator Hedelman, who's the Senate co-chair on our package of joint audit bills. And I also want to thank your wonderfully esteemed counsel, Amber, who also serves as our counsel on the Joint Audit Committee and spends a lot of time with us in the interim on audits and the policy. This is part of a package of 5 bills that we, as the Joint Audit Committee, have been working on that come directly out of a number of audits and sort of longstanding issues. And I think I don't really need to go into a lot of the issues that we heard on the audit as it related to the professional health boards. I think a lot of those issues were raised by many of you during previous bill hearings, but I think what was raised during that hearing, we saw that tenfold. And that's not to say that every board has issues, but there were certainly enough of them ranging from the administrative hurdles that we saw, issues around background checks, issues around just the time and processing and efficiency. And so what we did with this bill was really look at how we can bring together sort of all of the relevant stakeholders and come up with solutions. This bill is not meant to be prescriptive. There was, frankly, I think a lot of interest among Joint Audit Committee members to make a bill that was prescriptive, but we deliberately took a step back and said, you know what, let's create a commission that looks at really improving and streamlining the administrative functions of the boards. There's nothing in this commission that would look at the actual professional responsibilities of the boards for the areas and professions that they oversee. This commission would be purely about oversight, administrative hurdles. We also heard, frankly, and I think again was raised by members of the committee earlier, a frustration from the Department of Health, but also from the boards that when there are shortcomings, folks at the Department of Health feel like they are not legally or statutorily able to kind of make sure that issues are addressed. And frankly, we also heard concerns from the board that we know sometimes, the Department of Health will shift funding around in the budget. They will, often not necessarily be the greatest partner in longstanding history with these boards. And so the hope in this commission is really how do we bring everybody together from the General Assembly, the Department of Health, and the boards, and really look at, again, improving administrative functions. Is it the potential to create a streamlined application system that the boards can all use? Is it, combining IT procurements? Is it, streamlining background check systems to make things work better, especially for the smaller boards where duplication may just not be efficient and in the best use of what we know is ever-limiting tax dollars. And so that was really the work of this bill and putting the commission together. I also do want to recognize, I think she's still here, Hannah Dyer from the governor's team, who has been running point on working with us on this audit package and has really been a wonderful partner working with the governor, with the Department of Health, and the boards. The other piece of the bill is to also update the Office of Health Quality, the website, the Commission of Health Quality, the website information around inspections for facilities. One of the other things that we found in the audit, and I know this committee, as well as our colleagues in the health or HGO committee previously, had worked long and hard on particularly nursing home inspections. And so this bill would also require that that information is made public, that the information around inspections and the information from the inspections is posted on the website. That is why this is an emergency bill, because we want to stand the commission up as quickly as possible. We also want that information posted on the website as quickly as possible. And again, the folks at MDH and the Office of Healthcare Quality are perfectly supportive and have worked with us collaboratively on this. The last thing that I will say is we did make a number of changes. We worked with the boards collaboratively during the process in the House, and so the language in the bill, I think, reflects a lot of the suggestions from the board to make sure that we are not trying to be overly prescriptive, that this is truly a commission that is looking at sort of all problems to advise the General Assembly. The commission, we changed it to now be co-chaired by members of the House and the Senate. It's staffed by DLS instead of MDH, and we also added 3 additional members of the commission to represent the smaller boards as chosen by those boards. There's a specific call out for the 4 largest boards. We wanted to make sure that all of the boards felt like that they were represented on the commission. And this bill passed 129 to 1 out of the House. And with that, would be happy to take questions and would urge a favorable report.
Thank you, Delegate. So you have DLS staffing it. Why not OLA?
We felt like this was less of an OLA issue, and we are now moving into more of the policy territory. So that was actually in collaboration, Speaker's office and the Senate President's office and the folks at DLS. We felt like DLS was the best place for the staff, and they are comfortable with that.
Thank you. Thank you. Thank you for the bill. Thank you for being here. That ends the hearing on House Bill 1372, and now we're going to go to House Bill 1376.
Thank you.
Delegate Rosenberg, if he's here. And Maryland Medical Assistance Programs, Maryland Children's Health Program, and health insurance transfers to special pediatric hospitals. Thank you, Delegate.
Thank you, Madam Chair. Delegate Sandy Rosenberg, for the record. And if I may, Madam Chair, there are many people that I've served with in the House, obviously. And I was very gratified and pleased that when you became the chair of this committee, and we will miss you, especially being on your sister committee over on the House side, but look forward to working with you on other things in the future. Thank you. Certainly. The Mount Washington Pediatric Hospital has been a fixture in the Mount Washington community of my district for, I think, a century. So when there was a new CEO, I accepted their invitation to a visit, and at the end of a very pleasant visit, I said, were there any issues I can work on for you? This is that issue. Making sure that there is a prompt referral to this special hospital from an acute care hospital. And last year, we thought we had passed the bill that took care of that. There continue to be issues. In fact, last night, there were further amendments to the bill, which I'm pretty sure your council has, that make 2 changes. One that would make the effectiveness of the bill retroactive to January 1, 2025, in terms of if a referral was denied, it can be reviewed, it can now be reviewed. And then the second point was that the acute care hospital would have 3 days instead of 2 days to respond to a request for that reversal. These are amendments that were worked out yesterday evening by the hospital and by the department. These kids are special in many ways. The care they need, the hope that they have only if they get the right treatment. And our system shouldn't be delaying that treatment. It should be facilitating that treatment. And hopefully, House Bill 1376 will, as amended, will resolve that problem and would urge a favorable report.
Delegate, thank you for this bill. I know it's been a very serious issue, and
thank you.
We need to take care of the children. I'm not sure as a state that we're doing such a good job of that, but thank you very much for bringing the bill. Do I have any questions for Delegate Rosenberg? Thank you very much. Next, we have Delegate McCaskill, House Bill 1434, Maryland Department of Health Caregiver Resource webpage.
It's dwindling down in here. Good afternoon, Madam Chair and the rest of the committees, members that are left. For the record, I am Delegate Alethea McCaskill, representing District 44B. I am proud to present HB 1434, which is a bill that establishes and centralizes Caregiver Resource webpage within the Maryland Department of Health. This bill is a key component to the LEAD Act, in which I actually have, there are 5 bills in this LEAD Act, and I have been able to sponsor 3 that all have successfully came out of the House. The LEAD Act comprises of these 5 key pieces of legislation, and I am asking for a favorable report. Maryland law provides a clear and inclusive definition of caregiver. As stated by the Department of Legislative Services in the fiscal note, a caregiver is an individual who provides care, supervision, or assistance to another individual due to an individual's age, disability, chronic illness, cognitive impairment, or other functional limitations. This includes parents of children with disabilities or special needs care, adults caring for aging parents or loved one with chronic illnesses or cognitive impairment, young people providing care to parents, grandparents, and other adults. Caregiving in Maryland spans the entire lifespan, and caregivers exist in every community, every district, and every demographic group. While this webpage is needed, it is not redundant, and it does not mimic other websites. I am aware of the letter of concern submitted by the Maryland Department of Health to your committee. However, caregivers across Maryland consistently tell us that the hardest part of caregiving is not the caregiving itself, it's the bureaucracy, the maze of agencies, and the hours spent searching for accurate, up-to-date information. Fortunately, HB 1434 will help solve those issues. HB 34 does not duplicate existing systems. It simply fills the gap of caregivers, pediatricians, and statewide agencies that have been identified for years. Maryland has 211. It also has MAP and agency-specific portals, but no single plain language lifespan inclusive hub that brings together disability, aging, behavioral health, safety respite, and financial assistance resources in one place. Families report that they often do not know where to start, which agency is responsible, or whether the information they find is current. Navigators are not always available, leaving caregivers, especially those juggling work, school, and medical appointments, overwhelmed and isolated. This bill has support from the Maryland chapter of American Academy of Pediatrics, the ARC of Maryland, Maryland Senior Citizens Action Network, the Alzheimer's Association. Again, this bill ensures that Maryland existing resources are organized, centralized, and accessible, not scattered all throughout multiple systems or in PDFs and within other agencies. The Maryland chapter of American Pediatrics, who represents more than 1,100 pediatricians, submitted strong written support of this bill. They emphasized that pediatricians work closely with families navigating complex medical, developmental, educational, and social services systems. HB 1434 will be centralized, user-friendly resource hub that will provide care, coordination, and reduce unnecessary emergency department visits, which is a clear public health benefit. What HB 1434 does is it creates a centralized webpage that includes information on caring for children with disabilities, supporting adults with disabilities, caring for older adults, including those with dementia, caregiver wellness respite, state and local financial assistance and training programs, safety planning, including wandering and elopement, privacy, data minimization, and data security consideration. This structure mirrors the real needs of Maryland families and ensures that caregivers can find essential information without navigating multiple agencies. What HB 1434 also support is it's being a voice for Maryland family caregivers, and their testimony reinforces that. Maryland has over 1 million caregivers, many of whom struggle to navigate fragmented systems. Maintaining a comprehensive webpage requires ongoing coordination and subject matter expertise. The Commission recommends that they take on this responsibility to ensure the resource remains current and responsive. These recommendations strengthen the bill and ensures long-term sustainability. Why centralization matters across the lifespan? Well, caregivers face burnout due to consistent coordination and lack of respite, social isolation, especially for young caregivers and those caring for individuals with complex needs, and barriers to accessing financial assistance, training, and safety resources. HB 1434 directly addresses these challenges by reducing administrative burden, providing consistent, accurate, and plain information, helping families navigate transition across systems, and supporting caregivers at every stage. In closing, I ask that the committee to consider your own experiences navigating a website for critical information. Even the time and resources, it can be frustrating. Now imagine doing that while caring for a child with complex medical needs, an aging parent with dementia, or a loved one with disabilities during a crisis. So again, HB 1434 will make a meaningful difference for Maryland caregivers, and it is not redundant. I accept the Maryland Commission on Caregivers recommendation, and please keep in mind that HB 1434 can be handled with existing budgetary resources. Revenues are not affected, and for these reasons, Madam Chair and the rest of the committee, I'll ask for a favorable consideration on HB 1434.
Thank you, Delegate, and I don't see any questions. You did a good job. Thank you very much.
Thank you. Now I feel that you're going to be going on to enjoy the rest of your life. I'm finally coming over here to have all of my hearings here seem like so far. All right, thank you all.
Thank you, Delegate. I think I have Zach Blumenfeld here to present Delegate Hill's bill, House Bill 1249. This is certified recovery residences refusing services to individuals receiving medication-assisted treatment prohibition. Thank you. Thank you, Zach.
Oh, sorry. Thank you. Thank you, Chair Beidel, Vice Chair Hayes, and members of the Finance Committee. My name is Zach Blumenfeld. I'm a sophomore bioengineering student at the University of Maryland, College Park, and I currently serve as a legislative intern for Delegate Terry Hill. On behalf of Delegate Hill, I'm here today to introduce HB 1249. In a nutshell, HB 1249 prohibits certified recovery residences from denying housing to individuals solely because they use medication-assisted treatment, which is to say that they use counseling and therapy along with prescribed medications, including methadone and buprenorphine, which block cravings, or naltrexone, which blocks the euphoria experienced from opioid use. This bill also prevents these facilities from mandating that a resident modify or cease their provider-led treatment plan as a condition of residency. As a bioengineering student, I see this through the lens of evidence-based science. Medication-assisted treatment is the gold standard for clinically treating opioid use disorder, proven to both reduce mortality and support long-term stability. Refusing to accommodate these is often a manifestation of a stigma of trading one addiction for another, that it ignores the entire biological reality of this disease. By passing HB 1249, we align our housing standards with the existing federal non-discrimination laws and ensure that certified recovery homes are actually safe environments for all medically sound pathways for sobriety. Outside of the realm of science, this issue is close to my heart. I live with asthma. When I was younger, that required a strict daily preventative treatment plan. My inhalers are not a crutch or a substitution for healthy lungs. They are a medical intervention to prevent life-threatening flare-ups that allow me to continue to function normally. We would never dream of telling a student that the only way that they can live in a dorm is if they agreed to stop using their asthma maintenance inhaler. The same logic must apply to treating opioid use disorders. Just as asthma medication prevents an inflammatory crisis, medication for opioid use disorders manages the physiological symptoms of addiction, preventing the flare-ups of a fatal relapse. Forcing a resident to taper off their medication to secure a bed is not just a barrier to housing, it interferes with life-saving medical regimens and invites tragedy. I urge a favorable report on HB 1249. Thank you.
Thank you, Zach. Do I have any questions? I don't see any questions. Thank you for your testimony.
Thank you.
Delegate Alston. Delegate, you have two bills. Where would you like to start?
We can do the emergency petitions.
Okay, so that means you'll bring up, no, you don't have a panel, just
No.
a sponsor. Okay, that's good. You can start. Thank you.
Thank you. Good afternoon, Madam Chair, members of the Senate Finance Committee. I'm here today presenting House Bill 860, which is the Emergency Petitions Act. This bill seeks to clarify the use of force standard when serving emergency petitions. It also provides for a mechanism to have a petition extended if good cause exists as to why the petition could not be served timely, and the same factors that necessitated the petition are still actually in existence. Each petition for an extension would have to be filed separately, and it would also require, with the amendments being requested by the public defenders, that all of those documents be turned over as a part of the required disclosures. With that amendment, the Office of the Public Defender, Disability Rights Maryland, and On Our Own are now neutral in their position for the bill. And this bill is very important to our county. We lost 2 officers in the line of duty while serving an emergency petition. It also, under this bill, we are encouraging law enforcement officers to use best practices when serving these positions, including de-escalation techniques and having a CERT team or a crisis intervention team participate with them to the extent practicable. We understand that not all counties have them and they're not always available, but the intent of this bill is that they do utilize them. And so that would be House Bill 860. I'm happy to answer any questions.
I don't see any questions. Thank you, Delegate. I'm going to ask you to step back and bring up your one. We'll bring up your one unfavorable.
Okay.
Michelle Livshin, On Our Own of Maryland Incorporated, unfavorable.
Good afternoon, Chair Beidel, Vice Chair Hayes, and committee members. My name is Michelle Livshin, and I'm here today representing On Our Own of Maryland. We are deeply appreciative of the effort the sponsor, Delegate Alston, has taken to address concerns and thoughtfully add important patient protections and safeguards to the bill. It's truly meaningful that now the bill encourages the use of best practices and collaboration with mobile crisis teams and removes the word force. Altogether, the amended bill is the best version that we could hope for. Thank you. In terms of our formal position, we remain opposed, however. For over 30 years, we have stood against the use of force in behavioral health care, and we believe that explicitly linking the use of force to the EP process fundamentally reinforces the stigma of dangerousness with mental illness. National data shows that about 1 in 4 police killings involved an individual experiencing a mental health crisis, and recent events closer to home echo the deadly result of excessive force in crisis response. A police response to a behavioral health crisis can dramatically increase risk of arrest and fatal encounters, and this is particularly true of marginalized communities. We are grateful for the work, however, that Maryland has done to promote and invest in alternative crisis responses. With respect to law enforcement's request for clarity on their role, we believe that the most effective and safest way already exists in Maryland Police Accountability Act of 2021, with training on the force statute and de-escalation techniques. We are encouraged by the fact that some jurisdictions in Maryland are already improving outcomes without any change in statute. The experience shared with us by peers across Maryland show that current EP practices are inconsistently applied, and we strongly believe that the best and most direct solution would be informed by statewide data on EPs, which is proposed in Senate Bill 707 as amended. A data-driven approach has been recommended repeatedly by diverse groups of stakeholders, most recently in a 2021 BHA work group. EP standards impact thousands of Marylanders each year, and use of force by police fails to uphold the primary purpose of the EPs, to expeditiously establish safety for the individual and create significant opportunities for harm. Again, we deeply appreciate many of the amendments made to this bill. Thank you for hearing our concerns, and we respectfully request an unfavorable vote. Thank you.
Thank you for your testimony. Senator Jackson, question?
Yes, thank you, Madam Chair. You had said the use of force language was removed from the bill. Okay, but your opposition, you stated use of force. So can you kind of explain?
Sure. So one of the concerns previously was that the bill had said use of force per the public safety statute. Mm-hmm. We're grateful that Delegate Alston listened to the concerns last year and removed the word force. Mm-hmm. But it still does reference the use of force statute. It just removes the word force. So it says that officers can use best practices as it relates to the public safety statute for use of necessary and proportional force.
And this is a situation where officers are executing an evaluation or an emergency evaluation, or a home visit?
So this is when an individual with a serious mental illness mm-hmm. is a danger to themselves or others, okay. and there's an emergency evaluation called for them to be transported to the hospital for an evaluation.
And who transports them?
The police officers.
Okay, and if it's a situation where the police officer becomes in danger, what are they supposed to do if they can't respond to that?
Sure. So currently, the standard under the statute says that police can use necessary and proportional force okay. to any encounters. Okay. So what we're saying is by including it explicitly within a healthcare bill that it actually emphasizes the use of force when they're already able to use that force currently, if they're in danger.
So you're saying they can already do it. Your problem is that there's language in the bill that says that they can do what they already can do?
Our problem is that currently there's already an excessive use of force with police officers and mental health crises. So by including this, it just emphasizes the use of force and the association between mental illness and dangerousness.
I don't know that it emphasizes the use of force, though. I think they're going there to retrieve a patient if it's an issue where their safety becomes in danger. I mean, what would you do in that situation?
I mean, if their safety is in a danger, I think that would be covered within the public safety statute that already exists. And so the solution that we would recommend would be increased training if there's lack of understanding of what encounters officers can use force currently, mm-hmm. that we improve and look at the training that exists within the Maryland Police Accountability Act. So
if someone, a police officer's life is threatened, you're saying that training is supposed to help?
So my response
in that situation?
No, I think if their life is threatened, then they can use necessary and proportional force per the statute. Okay. Our rationale is that it doesn't need to be mentioned within a healthcare bill, especially as, like, most recently there have been incidences of somebody being killed by law enforcement when they were called. They were suicidal. They were going to harm themselves, and then that individual was shot. This was in March. In Baltimore, there were a number of other cases, and the Maryland Police Accountability Act was instated in part to deal with the police force and brutality that was happening in Maryland.
So if we took out the language that says must act in accordance with the Maryland Use of Force statute, you would be good with the bill?
We would become neutral on the bill if that line was taken out.
Okay. All right. Thank you.
Thank you.
Madam Chair.
Thank you, Senator. I don't see any other questions. Thank you very much for your testimony.
Okay,
We have one more. We have Public Defender Crystal Williams. She's going to bring us some information. Crystal?
Thank you, Madam Chair. And members of the committee, yes, I am here on behalf of the Office of the Public Defender, and I simply want to make sure that we are able to put forth our new position, because I know it has changed, and this is an issue that we have been working on some time and have had some conversations with Delegate Austin, and we are incredibly grateful for her working with us and reaching a point where we were able to offer additional language. And I think it might be helpful to clarify, too, that in terms of the consensus around the language, we did also reach out to Disability Rights Maryland as well as on our own. And I think it's fair to say that there is consensus on the new amended language. And so I think that if that's helpful to clarify that in terms of the position where we're all coming from. And specifically, OPD wanted this additional language because of the new records that would be put in place as a result of any extension of an emergency petition under the new statute. There does allow for some extension, new motions that go along with the emergency petitions if they are expired. And I know before we had previously sought, additional data or information that could be helpful, but this actually is really important for the litigation aspect of emergency petitions. And so because we are already entitled to the record of the emergency petition to be turned over to the Public Defender's Office as a result of somebody being involuntarily admitted, it makes sense to include that preceding information in any correlating motions that go along with that emergency petition. So that is really the main crux of why we offered it, and we are glad that it was accepted by the bill sponsor, and also speaking to stakeholders, they are in agreement with that amendment as well. So thank you.
Thank you for working on the bill, and thank you for letting us know that you're now in support of the bill.
But we are neutral. I wish we could get to a support. I tried.
You're not opposed.
We are not opposed.
Okay.
We are not opposed, and so I think that is a good place to be. I wish we could take it further, and if there's anything I can do to get us there, I will certainly make those efforts as well. So
thank you. Senator Jackson?
Well, I was going to ask you, I have a question for the sponsor. I don't know if that's the thing. We can call the sponsor back up.
She's going to be back.
Oh, she's going to be back. Okay.
Any other questions for
Thank you.
Delegate Austin, if you'll come back to the table, Senator Jackson has another question for you, and then we'll go on to your next bill.
Yes,
Okay?
ma'am. Thank you.
So in reference to the last person that came up before last, if we took the language, the use of force, the Maryland use of force statute, that language out of the bill, would that hamper the bill in any way? Would they still be able to?
Yeah, that would essentially gut the actual purpose of the bill. So the problem is this is a civil order that law enforcement has to serve. And so if it's not clear, and there are disputes, but now we've heard this bill like 3 years, if it's not clear in our statute that they are allowed to use necessary and proportional force, then they could effectively take this order to someone, tell them we're required to take you to the hospital, but if they touch them to put them in the car, that's a use of force. If they have to handcuff them, if they have to disarm them, all of those things are uses of force. The problem is because it's a civil order, you don't normally use force to serve a civil order. If it was a criminal order, it would be very clear, but it's not criminal, it's civil in nature. And that's where the problem is coming from. And that's why the sheriffs in our work group asked for this clarifying legislation.
Right. So the suggestion that they already, there's already a statute for that, the language don't need to be in this bill, they still won't be able to, I guess, protect themselves if a situation kind of spirals out of control in that kind of situation.
So law enforcement officers have to abide by the public safety article at all times. The concern is what happens if a law enforcement officer, when going to serve a civil order to take someone to the hospital, encounter a dangerous situation and they say, well, here's the order, we're going to leave now. And then they leave that situation where the person is still a danger to themselves or others. And so I think that the difference is there is just a fundamental difference of opinion as to whether or not we should ever emergency petition a person and take them to the hospital against their will. I believe that there are times when a person needs to go to the hospital to get health care and get treatment, and we want them to go to the hospital and not go to jail or to prison for committing a criminal act. And the question becomes, how do we safely do that so that law enforcement is safe, so that the patient is safe, and so that everyone around that person is safe? And what we are attempting to do with this bill is clarify for law enforcement what they can do. And when we changed the use of force statute, it used to be reasonable force is what they were using. Now it's nothing in this statute, in this section of the code at all. And I just think that our law enforcement officers need that clarity. And I do have the amendments that the Public Defender's Office requested. I can give that to committee counsel.
Thank you. Thank you.
Thank you.
Thank you, Delegate. So that ends the hearing on House Bill 860, and now we're going to do, Delegate Alston's going to do House Bill 1617, Public Health Innovation Zones Establishment.
Thank you, Madam Chair, Mr. Vice Chair, members of the Senate Finance Committee. I'm here today to present House Bill 1617, which is Health Innovation Zones. This bill seeks to bring much-needed health care into communities that have been traditionally neglected. In my district, we have pockets of areas where there are no primary care providers. There's a lack in maternal health. We have high prevalence of chronic illnesses like diabetes, high blood pressure, and obesity, and there are no treating physicians in close proximity to treat that. That is combined with the fact that we have a lack of grocery stores to provide healthy food options and a lack of pharmacies where people can actually get the medicine that they need to treat their chronic ailments. So what this Health Innovation Zone bill will do is to authorize local jurisdictions to create zones that will encourage the development of these types of businesses: grocery stores, pharmacies, primary care providers, specialty care providers, in areas that desperately need them. And some of those areas may be determined by their geographic proximity, because rural areas suffer some of the same problems that many urban areas do. So it can be based on geography, it can be based on race, immigration status, a variety of different factors. And the purpose is to make sure that we have these this flexibility and these encouragements in place so that we can get more providers where they are desperately needed. The bill originally came in with a $5 million fiscal note. The amendments have taken care of the fiscal note, and so we would ask for a favorable report on this piece of legislation. I'm happy to answer any questions. Oh, it does require Prince George's County to designate a health innovation zone along the Blue Line corridor as a part of our county executive's plan to bring more health care and more innovation to our established communities along the corridor. And so all of the rest of the state could do it by their own designation based on where they believe it would be appropriate. Thank you. I'm happy to answer any questions.
Delegate, did appropriations sign off on this bill?
We got rid of the fiscal note.
Well, you crossed out the amount. It doesn't get rid of the physical note. It just says the governor can put money in, but.
Oh.
Okay, I just wondered if you had a conversation with appropriations.
I'm happy to have one. They did vote for it. We did not have a direct conversation about what the monetary amounts would be, because we thought taking it out would suffice. I'm happy to talk to
We will have to have a
appropriate.
conversation with B&T. That's a requirement, so we'll do that. Thank you very much. Do you have any other questions, Senator Mounts?
Thanks, Madam Chair. And so for the innovation zones, the counties would have to opt in to create one?
Yes, the counties would have the ability to create one in areas that they deem are appropriate. So like on the shore, I know there are a lot of rural health concerns and we need more medical providers on the shore. I think that one of the counties there or several counties together could designate a zone and then they could determine what's necessary to encourage the development of those businesses there. One of the things would be like expedited zoning approval.
Okay. Interesting.
Thank you.
See any other questions? That ends the testimony on House Bill 1617. And now we have a full hearing. Senator Hershey. This is a late file Senate Bill 1008, alcohol and cannabinoid beverages off-premises sales permit. It's Senator Hershey, the sponsor. Christina Johnson is favorable, and Joe Price is at the table for favorable. Thank you.
Good to go. Thank you very much, Madam Chair, Vice Chair, members of the committee. For the record, Senator Steve Hershey to present Senate Bill 1008. Madam Chair, I greatly appreciate the opportunity to bring this late file bill. As you know, we've had a lot of work that we've done with both the alcoholic beverage and cannabis industries on this. So broadly speaking, consumer demand for low-dose THC-infused seltzers and drinks, those containing 5 milligrams or less of THC per single serving can or container, is growing steadily in Maryland and across the country. For those who may be unfamiliar with these low-dose THC-infused drinks, they're similar to seltzer-based alcoholic beverages sold in single-serving aluminum cans, drinks like White Claw, High Noon, Truly, that are sold in liquor stores throughout the state. With regulatory oversight that utilizes the collective expertise of both the Maryland Cannabis Administration and the Alcohol, Tobacco, Cannabis Commission, Senate Bill 1008 presents Maryland with an opportunity to become a national leader in responsible low-dose THC drink distribution through local liquor stores in our respective counties for off-premise consumption only. The bill includes a balanced regulatory framework that, 1, requires low-dose THC-infused beverages to be produced by licensed MCA cannabis processors. 2, protects Maryland consumers by maintaining all MCA product testing, labeling, and packaging requirements under current law for THC beverages. 3, authorizes counties, but does not require them, to allow broader distribution of low-dose THC beverages through traditional 21-plus-year-old liquor stores for off-premise consumption only. And 4, based on the DLS fiscal note, provides potentially significant general fund revenues for the state without raising new taxes, along with meaningful benefits to small businesses that hold MCA cannabis processor licenses. I want to briefly discuss what is allowed under current Maryland law, followed by the additional distribution framework authorized under this bill. Under current law, an MCA licensed cannabis processor can already manufacture THC-infused drinks, currently defined as liquid editable cannabis products that contain up to 10 milligrams of THC per single serving can or beverage container. These THC drinks are currently sold in a number of the state's 111 retail cannabis dispensaries. Based on the DLS fiscal note and industry data, THC drink sales currently make up less than 0.05% of overall retail cannabis sales in the state. That's less than 0.5% of the state's cannabis market. And the percentage of low-dose THC drinks that this bill is talking about, those with 5 milligrams of THC or less per serving that are sold in the state's retail dispensaries, is much smaller than the 0.5%, and practically speaking, is non-existent. Even DLS acknowledges that current sales of THC beverages generally are limited due to the number of dispensaries, sheer sheer space limitations in their current retail footprints and regulatory inventory controls for bulky cases of THC drinks. Senate Bill 1008 maintains exclusive ability of our state's cannabis dispensaries to continue selling every single project that they can today, with a single narrow exception that also authorizes low-dose THC beverages to be sold in off-premise liquor stores. Specifically, this bill authorizes a Class 1 beer, wine, and liquor wholesaler to acquire low-dose THC beverages from only MCA licensed cannabis processors that meet all existing MCA standards and requirements. 2, deliver the low-dose drinks to local liquor stores that have been issued off-premise low-dose THC beverage sales permits by a local liquor board. Senate Bill 1008 also maintains all existing local authority for our respective counties' alcohol leverage licensing boards. On page 7 of the bill, a county must affirmatively adopt regulations to allow for low-dose THC drinks to be distributed and ultimately sold in local liquor stores for off-premise consumption only to individuals that are at least 21 years old. This bill does not allow low-dose THC drinks to be sold by any other alcohol licensees or those with on-premise privileges like bars and restaurants. It is also important to note that low-dose THC drinks would be taxed at 12% at retail. This would maintain consistency with the cannabis sales tax rate that applies to all of our dispensaries across the state. I want to reiterate a point on page 6 of the DLS fiscal note that I mentioned earlier. General fund revenues increase beginning in fiscal 2027, potentially significantly due to sales and use tax revenues from the sale of cannabinoid beverages. While this bill is silent in certain areas like in-store marketing and signage, I would certainly defer to the expertise at ATCC and MCA to collaboratively work together on appropriate guidance for Maryland consumers. In addition, this bill allows anyone to apply for a Class 1 wholesaler's license from the ATCC to distribute low-dose THC beverages. I'm currently working with the Amendment Office on 2 amendments that would, 1, create a optional THC beverage permit for any Class 1 wholesaler license, and 2, also allow micro-dispensary licensees to distribute cannabinoid beverages to off-premise retailers. I respectfully ask for a favorable report from this committee. Thank you, Madam Chair.
Thank you. Christina, you want to go next?
Sure. Chair Beidle and Vice Chair Hayes, members of the committee. My name is Christina Betancourt-Johnson, and I'm here today as the board chair of CanMed, our state's wholesaler association. This bill addresses a simple but very important reality, and that is that consumer demand is evolving, and our regulatory and statutory framework should evolve with it. Low-dose THC beverages, those at 5 milligrams of THC or less, represent a distinct emerging category that really is not meaningfully penetrating our market right now. Today, beverages account for a fraction of the overall cannabis sales. As the senator earlier stated, it's less than 1%. It's our association's opinion that Senate Bill 1008 does not harm our Maryland dispensaries. In fact, they retain full exclusivity over higher dose products and can continue to sell beverages. What this bill does do, however, is it creates an additional controlled distribution pathway for low-dose products that currently are underperforming in our system. It's an opportunity to build and create, essentially, a product category that can support the growth and legitimacy of our sector. While some will raise concerns, as I'm sure you will hear, about market impact and revenue shifts, we know that beverages sales right now, again, are at 0.5% of total cannabis revenue. 0.5%. That means that any potential displacement is minimal and largely theoretical at best. What is not theoretical and what's before you all today is the opportunity to expand distribution, which will create new revenue streams for Maryland processors, the ability to improve product accessibility for consumers across the state, and it generates an additional and sizable tax revenue for the state without increasing taxes. This is a measured, narrowly tailored bill that maintains regulatory integrity while allowing the market to function more efficiently. On behalf of CanMed, I respectfully urge a favorable report. Thank you.
Thank you, Madam Chair, members of the committee. Joe Bryce here on behalf of CanMed. First, Madam Chair, unless I do something wrong in the next 2 weeks, this is probably the last opportunity I'll have to be in front of you. And I just want to tell you how much I appreciate the 20 years of working with you. I won't repeat much of what was said. The big points, I think, are that this is an untapped market. When we speak of the size of this market now, which has had the same ability to grow over the last 3 years as every other component of the cannabis market, which has grown. Maryland received $72 million in tax revenue from cannabis. $650,000 of that was from beverages. Sales were $1.2 billion with a B, and beverages were $5.5 million, less than 0.5%. We certainly understand concerns raised in some of the testimony. Advertising, those types of things would have to be worked out, integrating the two regulators, certainly, and the distribution of the tax revenue. The bill's drafted to send all the money to the general fund. That really was just patterned on what you did with the most recent 3% increase 2 years ago. We obviously are supportive of however this committee and the state wants to spend their money. But I think and we certainly, the dispensaries are our partners. They're going to continue to be our partners. The simple fact is that this puts beverages in the hands of people who sell beverages and have the inventory and the ability to move and the infrastructure that most dispensaries would never have. Madam Chair, you will see some testimony that the beverage category has increased 122% over the last year. But if you look at the numbers, that means it went from 0.025 to 0.05. So just to keep it all in context, happy to answer any questions.
Senator Guile.
Yeah, thank you, Madam Chair. Thank you, Senator and panelists, for spilling your testimony. I guess Joe, I mean, I've heard it been said that why can't we just let the dispensaries, I mean, I know you're saying probably that they, liquor stores already have refrigeration and et cetera, but why can't we allow dispensaries just to have refrigeration and do it themselves? Or are we circumventing them?
Thank you, Senator. I don't view this as circumventing them. They can have that right now. They can have refrigeration. They can have a big stock room to stock these beverages. But I think the market has shown us that that is not a product line that the dispensaries view as a viable profit margin, whether it's space or price or whatever it is. It's also expensive to produce these beverages. Canned beverages are a more costly thing, and without a wide distribution network, processors aren't going to invest money to sell into less than 1% of the market. They will continue to be allowed to sell everything over 5 milligrams. They will be able to sell these beverages as well in their stores. The Class 1 licensees are just another distribution outlet. But I think we're very sensitive to the fact that we all rely on each other to make the cannabis industry successful and safe. And but you can't remove a market that isn't there. And right now, it's not there.
Mm-hmm. And the Maryland Dispensary Association has submitted written testimony, and I mean, I guess the majority of the written testimony are just a lot of questions. And I mean, among the many questions that they seem concerned about seem to be more related, I think, to security type concerns. Do you anticipate then folks that work in liquor stores that going to have special training in order to handle these products, or additional background checks and screening and et cetera?
Sure, thank you. So that is not addressed in the bill. I acknowledge that. That is something that we would have to work through with the Maryland Cannabis Administration and the ATCC on those types of things. The reference is to the fact that under cannabis laws, you have to lock everything away in your dispensary in a secure vault at the end of the day. So you can imagine you're not going to build a vault to hold
For your fridge, for your
pallets
beer fridge.
of, right, or a beer fridge.
Yeah.
And so that's the reference. But
If you got one of those, I got a teenager, so I may want that.
So I think that's a practical challenge, but there are absolutely things that would need to be resolved. We're all for regulating it as tightly as we regulate things currently.
Okay, and just one last question, Madam Chair. I mean, we've experienced a lot of issues, I think, in all of our respective districts and counties regarding pushback from community members and concern as far as zoning restrictions and how much county input could have here. I mean, how do you see that playing out, especially given that this is really contemplated for existing liquor stores?
Right, thank you. Yes, it would be existing locations, first of all, and as Senator Hershey mentioned, the local liquor board can say nobody can sell these.
Okay.
They're allowed to control what's sold in those stores, and they keep that control under this.
Right, okay, all right, thank you. Thank you, Madam Chair.
Senator Kramer, you turn your light off?
I figured I'd wait to hear what the vice chair.
That's not fair.
And then I'll see if
Mr. Vice Chair?
No, thank you, Madam Chair. Excuse me, I'm sorry. I was looking at the letter of information from MCA, and they pointed out the fact that the proposal would lower the sales tax. Is there, what was that all about?
I believe, I've spoken with them, I believe that was, they misread it and misstated it in their testimony, so I believe, I don't know if they're coming up, but it keeps the same exact provisions regarding the actual tax as the current law does. So I brought the wrong, no, I brought the wrong bill. If you want to know anything about Laurel Park, I've got some stuff here. But I refer you to the page number if someone has it handy, but it is still 12%. It's distributed under the bill to the general fund, but that's really just because that's how you did the last one. However, the committee chooses to distribute the revenues is obviously up to them.
Right. I guess the other concern that I would have, I literally just left the Glee Committee over there in the House testifying on the bill to limit hours of our liquor stores. In the parts of Baltimore that I represent, we have an over-concentration of liquor stores. We have more liquor stores than recreation centers, supermarkets, grocery stores, and churches, right? But part of the testimony that the owner testified to is that they provide a service to the community. So in addition to beer and wine and liquor, they also serve potato chips and candy and all that other stuff that folks come into the store to buy. And so I wonder, like, why wouldn't we keep like the cannabis products in the cannabis dispensaries versus like open up Pandora's box and letting these type of establishments?
Sure. I mean, we're happy to give out candy if that's helpful in this. But I think, Senator, it's a fair question. I think that the market has shown itself over the last 3 years that this isn't going to grow within the regulated cannabis system for all the practical reasons that I mentioned about cost of purchase and distribution and storage and all those other things. The second thing is when you look at how this has been across the country, this is like, as Senator Hershey said, this is like a White Claw or a High Noon or those other categories that are taking foot in the alcohol industry and replacing beer. And this is much more akin to that. So it would be more of somebody may not want to go into a dispensary for whatever reason. There's still that stigma, which is, it is what it is. But if you're going to buy beverages, there's the place that sells beverages, and all the operating hours and all the other problems and issues and services you mentioned are unchanged by this.
Right. I guess I'm looking at like the ages, right? So in order to go into a dispensary, you have to be 21, I think. In order to go into a liquor store, there's no minimum age limit, right? And so you now have a scenario where 8-year-olds and 10-year-olds that's going to buy a bag of chips will be entering establishments with some of these products, as they do now with like liquor or whatever.
Right. They
right, but we're further exposing them yet again to another substance.
Sure, and I appreciate that concern. I think that, as you mentioned, they're already seeing alcohol, but there are also ways, as we've done in the dispensaries, about how you can display it, where you can keep it, how you market it, who can physically grab it, all those things that would be worked out in a way that the child is not going to pick up a seltzer because they think they're getting a vitamin water or something. You can still restrict the access and the view to these things.
Right. And lastly, there was some testimony that was provided in there's some concern that having this available in some of the liquor stores may provide greater competition and put social equity license at a disadvantage, as many of them still continue to try to get online. I guess I would ask, how would you respond to that?
Sure, and that's obviously something we've worked with the committee on for the past 10 years, was to make sure that those licensees got established and got off the ground. I think first I would go back to no one, for all intents and purposes, a very small amount of people are doing a very small amount of business in this category currently. So we're not pulling out a revenue source that's 30% of their sales. It's less than 1%. Secondly, on the social equity side, there are two things I guess I would mention. One, anyone can get the permit to deliver to the Class 1 licensees. So anyone can start their own thing or continue their own thing, or however they want to do it, and get into the distribution between the processor and the liquor stores. And the last thing I would say is to the extent that it's possible for individual social equity processors, this is a whole brand new market with very, very little competition that they would hopefully be able to sell into.
Gotcha. Thank you, Joe. Thank you, Madam Chair.
Thank you.
Thank you, Madam Chair. And I apologize because I too was over in the House listening to the Vice Chair's bill being discussed in the Glee Committee while I was awaiting my legislation. So I missed the introduction, and I'm so very sorry I did, because I'm looking at the sponsor of this legislation and the subject matter, and I know Senator Hershey has been a big proponent of cannabis in the marketplace. So, when I see this, I go, oh, it's just an extension of all that enthusiasm and support.
He does love taxes also. This is a big tax generator, so I think that was probably what got him behind
of
it.
cannabis. So, but am I correct that just on its face value, the purpose is to allow cannabis-infused beverages to be sold in beer and wine stores or liquor stores?
Class 1 licensees.
And explain to me, is that beer and wine stores?
I have this racing bill. That's about all I can get it.
Liquor stores.
I believe that it is beer, wine, and liquor.
Okay. So if could it be just any beer and wine then, or would it have to be beer, wine, and liquor?
The way it's drafted, it would include that entire license category. I think you've done other things in the past to.
So, for instance, in Montgomery County, liquor is strictly the county. Mm-hmm. So would beer and wine stores be selling this product, or only Montgomery County liquor stores?
So keep in mind, Senator, that the local liquor board would maintain control over who can get these licenses.
Yeah, I heard that about cigars and, but yeah, okay. And I don't, my full faith and trust is not with our local liquor boards, but so how does that play out?
Again, it's drafted in a way that any of those premises that you mentioned, if they apply for and get the permit and approval from the local liquor board, would be allowed to sell the beverages.
So it could be just, a beer and wine store. Got it.
Yes.
Okay. All right. And then there was some discussion of a limitation as to the percentage of the infusion of cannabis in the beverage. Is that?
5%.
Yes, it would be up to 5 milligrams of THC per container. Right now, in a recreational cannabis dispensary, you can get drinks that are 10 milligrams per serving, and you can get higher dosage drinks in the medical program. But this is for the lower end of that category.
Is there a House bill, companion bill to this, a cross file?
We are the only fortunate chamber to have this bill.
Because I note it has come just a tad deep into session, and
as you can see, it took a lot of work.
I didn't know whether there was an explanation that I missed in the beginning.
Yes, you did. It did take a lot of work, obviously, to get the alcoholic beverage industry and the cannabis industry together on this, and it did take some time to do that. And I did thank the chair for allowing us to get it out of rules and have this hearing.
All right.
And we had to prepare for your questions. That added another month and a half.
I was just waiting for the good vice chair, and he covered a lot of territory. So thank you very much.
I think I made the motion to get it out of rules. Senator Mounts?
You did, that's right.
Thanks, Madam Chair. I was doing the Google search, it's the popular thing, but so with the bill, this would allow for the sale in beer and wine, liquor stores, however the counties decide, but would also allow for sale, on-site consumption in bars and restaurants and things like that?
No, this is, Senator, you want to talk about that?
Just strictly off-premise only.
Off-premise
Very
only.
specific, it is not for any on-premise consumption.
Okay. Well, I was interested to see how that works. I was searching online where it's allowed, in the U.S. I saw where, the Minnesota, Illinois, Colorado, California do it, and so does Florida and Texas, But Joe, so I stay in touch with my distributors, and I'm very aware of what's happening with their market, with the legalization of cannabis. And, I've been told that the drop in sales is directly correlated to the increase or the legalization of cannabis. Do you have figures or numbers that can verify?
I do not. Someone behind me may, but I've heard the same thing. There's no doubt that when you read the trades and everything, the beer consumption particularly is way down, and the category that I mentioned of the White Claws and everything else is going up, but alcohol sales generally are down.
And then for the sales of cannabis right now, what percentage are the beverages coming out of the dispensary? I mean, as far as the sales of what's being sold out of dispensaries, or how is it? What level is that?
Yeah, I mean, so the most popular one, Ms. Johnson can answer also, but the most popular is the 10 milligram, which is the highest dose allowed under the law.
Yes, we have three different brands right now in the market. I think you'll have other dispensary owners up here speaking to this. I am one as well. It varies by dispensary, what they represent as a total percentage of your individual sales, but in the market, it's less than 0.5%, all of them, all the current brands.
As opposed to all the other cannabis products that are available.
Correct. The different modalities. Yep, flowers more than 50%. This is less than 1%.
Thank you.
Sure, thank you for your question.
We're done cross-examining this panel. Thank you very much for your testimony.
Thank you, Madam Chair.
We have, I think Brad Rifkin can't be here. He's across the hall. Obi, are you here, Obi Chenamar? Nope. How about Nick Manis? So Nick, you're up here all by yourself as a favorable,
Okay,
but I know you can handle it.
all righty then. Thank you, Madam Chair, Mr. Vice Chair, members of the committee. My name is Nick Manis, here today representing the Maryland Beer Wholesalers Association. We distribute alcohol beverages throughout the state, and I'll be brief. We are here in support of Senate Bill 1008, and should the state decide to allow THC beverages in packaged goods stores the Maryland alcohol beverage system is the best way for that to be accomplished. It is a proven system for highly regulated products that allows the state to properly collect taxes, monitor the marketing and sales practices, allows for quick recalls if necessary, and provides consumers with safety by having a secure, traceable chain of custody. Most states that allow THC beverages in packaged goods stores utilize a distribution system just like Maryland. So a lot of distributors, alcoholic beverage distributors, all the ones that distribute this in states that allow it. And my final comment, like Joe said, Madam Chair, hopefully this is my last time for you that I'm before you, and the committee members and all of us at Manus Canning appreciate working with you over the many years, and most importantly, we appreciate your friendship, so thank you.
Thank you. See, they all think they're going to get votes by talking nice to me. Thank you, Nick. Mr. Vice Chair?
Yep. Thank you, Madam Chair. Nick, do you think adding these beverages to grocery stores might increase the profit margins for some of our supermarkets here in the state?
That's a very good question, but as you said earlier, with minors that go to the grocery stores with their parents, especially their mothers, I don't think you want to expose them where they're buying bread and milk.
Oh, got it. Thank you so very much for your testimony today.
Yes, sir.
That was a loaded answer. Thank you. Thank you, Nick. I don't see any other questions. We have Carrington Anderson here for favorable with amendment.
Thank you, Madam Chair, members of the committee. My name is Carrington Anderson here on behalf of the Maryland Association of Counties in support of the bill with amendments. You have our written testimony. I do want to say that MACO has no concerns with the intent to establish a regulated market for cannabinoid beverages. Our concern has to do with all of the sales tax revenue under this bill going to the general fund. Counties do ask for a share of that, similar to existing cannabis structures. In fact, we would really like the General Assembly to broadly consider the cannabis revenue structure and either allow counties to have the option to have a local tax option or to increase the share that local governments get from the state revenues, similar to other states. And just a quick example of how limited the amount of revenue that counties get from this is if there's a $100 cannabis purchase with the tax, the state gets $12 and counties get 45 cents, and they then have to share that with the local municipalities. So for these reasons, we'd respectfully ask for a favorable with their amendment support. Thank you.
Thank you. Follow the money. Thank you, Carrington. I don't see, Senator Hershey.
Yeah, thank you very much, Madam Chair, and thank you, Carrington. And as we have discussed this several times, I really do think that the counties got undercut in the distribution of the tax from all of this. But as we said in the panel hearing earlier, we just put everything in the general fund right now, and that to be the committee's decision on how to separate. But I think you have a number of people that continue to advocate to make sure that the counties maybe get a little bit higher percentage of that overall. So thank you.
Thank you. Appreciate it.
Thank you. I don't see any other questions. Thank you very much, Carrington. Now we have Warren Lemley, Maryland Dispensary Association, unfavorable.
Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the Finance Committee. My name is Warren Lemley. I am the owner and president of Maryland Cannabis Dispensary and speak here today as the chairman of the Legislative Policy Committee of the Maryland Dispensary Association. I am here today to testify unfavorably of Senate Bill 1008. The MDDA is in opposition of this bill. We have been the one and only cannabis license to lose revenue streams. Medical delivery has been expected to be removed, and now there's a chance THC beverages are going to be sold outside of dispensaries as well. THC beverages are a fairly recent product entry. As mentioned, there's only 3 in the market, and we expect that demand to grow over time. Why are we removing streams of revenue while expecting so many new dispensaries to successfully come to market? We don't support this bill in its current form and emphasize that if THC beverages are able to be sold at beer, wine, and liquor stores, then they should be distributed by dispensaries. We believe licensed cannabis dispensaries should be the sole retailer and or distributor of all intoxicating cannabinoids, including THC. I would like to highlight some concerns and questions if we are legitimately considering selling THC beverages outside of regulated and licensed dispensaries. Will people between the ages of 8 and 20 be able to enter their establishments? Will THC-infused beverages be allowed to be seen from the public, or will they also have to have privacy films, and will they have to have the same restrictions on operational hours, advertising, and zoning as dispensaries? Will their customers be able to pick up the beverage before purchase because cannabis dispensary customers cannot touch products before they're sold to them? Will their businesses be allowed to continue the use of credit cards and normal banks? Will they pay additional licensing fees? Will their employees have to have background checks, become cannabis agents, and take responsible vendor training? Will their stores have to install vaults, secure THC beverages in them, and return those products to the vault after non-operational hours? Will their businesses have to install facial recognition cameras, track their employees' movements through access control systems? Will they have to track their green waste and product damage for the MCA? Cannabis dispensaries had to traverse all the regulations listed above and more. It is our hope that any business with the ability to sell THC products would be subject to the same requirements as dispensaries. I urge an unfavorable report on SB 1008. Thank you much, and I would love the ability to answer some of the questions that were asked actually earlier today.
Senator Hershey?
Thank you, Madam Chair. And Warren, thank you very much. And I do want, I will let you answer some additional questions because I do think that that's what we're trying to do right here with this late file bill is to get some of these issues out there so that we can discuss and possibly work on this in the interim if that's where this ends up going. But you brought up a number of very good questions about the regulated side on what you have to do with cannabis products in the dispensaries. Obviously, liquor stores would probably have to be treated a little bit differently. And I don't know if that's because, this is a THC infused drink in a, metal aluminum container that's very different than sometimes the products that you're selling. But maybe you can tell us a little bit about, you mentioned that there's 3 THC infused products that are out there right now. Do you guys sell them, and is the market fairly accurate to some of the numbers that we proposed earlier as far as the amount that you sell?
Yes, it's fairly accurate, and I do believe you've notated some of the reasons as to why it can be difficult. I personally do carry them. Actually, I do carry them in a refrigerator, so when you come and you purchase them from our dispensary, they are cold, so it can be done. Honestly, one of the things that I wanted to speak about is that if dispensaries were given some of the same leeways that we're discussing giving these liquor, beer, and wine stores, and we could actually store these outside of a vault, if they didn't have to be put back into a vault, they could just stay on the retail floor in a refrigerator like they would at a beer store. Maybe there would be more opportunity for these to be sold at dispensaries. And I would certainly like to see the ability or the chance for dispensaries to be able to properly access that market if that is the goal before moving towards a different retailer or providing or mixing alcohol and cannabis or anything of the like.
Right. When you said you keep them in a refrigerator, and again, I think one of the things that we're trying to address here is actual distribution of the product, right? Correct. Because it's a very different type of distribution, just in the bulkiness of, a case of these cans or however. Do you keep, when you get a delivery of them, are you getting like a substantial amount that you're keeping a certain amount in the storeroom and then bringing some out, or how are you handling that as far as how much inventory you can actually have at one time?
Certainly. We have a refrigerator that we keep in our vault, and we have a refrigerator that we keep on a retail floor. Now, as mentioned, products have to come back into the vault during non-operational hours, and they do so every single day. But what we'll do is we'll take the amount of cans that we'll have and we'll put them in the refrigerator so that they are cold for people when they want to purchase, similar to what they might do at a beer, wine, and liquor store. One of the things I wanted to point out, because you kind of nailed the fact that these products are typically distributed by pallets and take up a large amount of space. If we didn't have the same restriction of them being in a vault, then there might be much more opportunity for dispensaries to be able to participate as a wholesaler. So at the end of the day, if, for instance, I ended up at our dispensary location, we ended up doing an expansion and we had a new retail floor. I have a spot in my retail floor of about 800 square feet that it's just being used kind of casually for office space at the current situation. If I had the opportunity to be a distributor, then that was something that, you know, me and possibly other dispensaries might be able to participate in. But currently, that's not a possibility under the current regulations.
You mentioned being a distributor. You mean as a dispensary or as a processor?
Well, no, I just mean like if there was a world, first off, I think that all THC and THC products should be sold through dispensaries. We are trained for this. We do all the training for it. There's all the experience that's been involved in it, not to mention all the you know, taxes and everything we've been through. Obviously, I've spent a lot of time in this finance committee, so I appreciate you for that. So, I mean, I think that from my perspective, it should stay in the dispensaries. Frankly, the dispensary associations, it should stay in the dispensary. If there was a move to allow beer, wine, and liquor stores to be able to carry these products, then I think that dispensaries should be the ones that distribute those products. And whether or not there's some sort of partnership, if that forms with a beer, wine, and liquor store, and maybe a dispensary is required to train said store, I'm not sure what would be in store for that. I personally don't think that is the route that we should be going. But I also don't think that we should take a stream of revenue from the cannabis industry when we're trying to expand it and then hand over that source of revenue to a different industry.
Okay. I think one of the amendments that we have, and you probably have not seen it, was to allow anybody to apply for the distribution license, right? So that you could be the individual that, you know, brings it to the beer and wine stores, if that's appropriate. We were looking at that. But just go back to the product itself. This is for low THC infused drinks. Obviously, the dispensaries would still be able to do anything 5 milligrams or more. What is kind of the product lineup that you have as far as the infusion of THC in these drinks?
As I mentioned, 10 milligrams is typically the product that we do carry. If there was a demand, then we would be happy to carry it. To that point, obviously, there hasn't been as much of a demand, but I don't really think there's many of those products available to the market either. And so, you know, I would argue that we should try to have more products available to the market, maybe bring more appeal to it. We had a lot of people talk about it's about 1% of the industry currently. Well, I just want to point out that 1% of $1.2 billion is a successful dispensary. You know, at that point, we are basically taking the lifeline out of one dispensary, and we're removing that just as the product stands right now.
Well, it would be the same half a percentage point for that dispensary, right?
But at that point, we're talking if it's between 0.5% and 1%, that's what, $6 million to $12 million, and that's an expanding product line. So, I mean, by argument, if you were to take a dispensary that maybe have a slightly low overhead, then that would make it a successful dispensary. So in my opinion, we're taking the revenue that would support one successful dispensary, and we are removing that from the cannabis industry.
Okay, and so just to finalize, the biggest challenge for you to be able to sell these types of drinks in your dispensary has been some of the requirements that we put upon with respect to having it in a vault, locking it down, and space.
100%. You know, we have to, everything has to fit into our vault at the end of the evening. To that point, these beverages do take up a substantial amount of space, and it does limit the amount that we can hold at any one point in time.
Right. And if we move forward with this bill, we would probably have to address that with respect to beer, wine, and liquor stores as well too. And we want to put them to be some type of parity with respect to that.
And that's what we're really looking for. I mean, we're talking about metric ending when it lands to a beer, wine, and liquor store. So the gentleman up previously was stating that they'll still be tracked and traced, but that is simply untrue. I mean, once that product goes to the liquor store, it's not going to track which customer purchased it. So at that point, there is no more traceability once it goes to a beer, wine, and liquor store. So, you know, as the Dispensary Association, we just want to make sure that if someone is given the privilege to sell THC, which it is, and that's why we have to go through so much to be able to provide the service to our community, we just want to be able to have the same rules and regulations that are going to be given to anyone selling the same products.
Understandable. Okay. Thank you very much. Thank you, Madam Chair.
Warren, thank you for that. Gave us a lot to think about.
Thank you.
I don't see any other questions. Thank you very much.
Thank you.
And finally, we have Selena from the Maryland Cannabis Association.
Good afternoon, Madam Chair and members of the committee. My name is Selena Raleigh, and I'm providing information only on SB 1008 on behalf of MCA. SB 1008 would establish a new permit allowing THC beverages to be distributed through the alcohol retail system, and we just have a few potential impacts that we'd like to note. First, this bill poses a risk to Maryland's licensed cannabis dispensaries, as you've heard. I understand the point about the percentage change. That said, THC beverages are one of the fastest growing product categories. So that 122% change that we've seen in sales was just in 1 year, 2024 to 2025. So by shifting this high demand product into the alcohol retail market, the bill is diverting this consumer traffic and revenue away from dispensaries that were intentionally designed to serve as exclusive retail for cannabis products. Although dispensaries would still be allowed to sell these beverages, the difference in scale is significant. Maryland has just over 100 dispensaries compared to thousands of alcohol retailers. This expanded access could shift purchasing behavior towards more convenient outlets, reducing dispensary foot traffic. Secondly, the bill introduces dual regulatory frameworks that risk creating ambiguity in how advertising laws, which were just amended by this committee, apply to THC beverages. Currently, MCA regulates cannabis advertising, enforcing a set of standards that were established by the MGA. The bill does not exempt THC beverages from these requirements, while also subjecting them to advertising laws that are applicable to alcoholic beverages, which are fundamentally different and more broad than cannabis advertising laws. This overlap could lead to inconsistent interpretation, increased compliance costs, and broader advertising such as billboards or storefront promotions that don't align with existing public health safeguards. And finally, THC beverages sold through alcohol retailers would direct revenue solely to the state's general fund, as you've heard, and this change would ultimately reduce funding for the CREF, which supports public health programs, several agencies, community reinvestments, and local governments. We respectfully encourage careful consideration of the potential impacts of this bill on Maryland's regulated cannabis market. Thank you for your time.
Thank you, Selena. Do I have any questions? No. Thank you very much, and that ends the hearing for this bill and ends our hearings for today. Tomorrow we will have hearings again at 1 o'clock, and that should be the end of our hearing list. So thank you all for your time this afternoon.